the lesion. It's more difficult on the right, but there are fibrosis. But when there are fibrosis, you have to ask where is the good layer, and you use the cap to recline to make the fibers in tension, but we can discuss. For the dissections, I propose different rules. Never work in a declive area, and try to not work in this submerged area. Then you can change the patient, the position of the patient. And of course, you have to control the length of ESD knife, and I recommend you to inject as often as possible. Your objective is to expose the submucosal fibers to have a better visualization of the operating field and to give appropriate counter-traction and to do the dissection. How to obtain a clear field of view? I already discussed about the transparent hood, but you have to use the gravity. You can use different technique, and we will use this technique during the lab session. The clip line or the clip snare to track the lesion and to better expose the fibers. And you can, of course, like here in this image on the right, submucosal tunneling in the esophagus. Of course, there is a pre- and post-operative control. We will have a topic for the management of complications and perforation bleeding. Try to close the scar after ESD, but it's very difficult because sometimes and more often the scar is very large, and you have to send the resected specimen to your pathological unit. This is a demonstration of Wirecast. Conclusion. I propose you 2 steps. First steps, diagnostic, to analyze the limit of the lesion, to predict the depth of an invasion, and then the lymph node invasion. And second step, to begin your treatment. And always you have to ask, what is my strategy now, before beginning the dissection, before beginning the resection. Please try to be in the best conditions, and the learning curve is important. And you are here now today to practice on animal model, and I think it's very important to use the endoscopes and accessories adequate. And the sedation in my country, all the patients had general anesthesia with tracheal intubation, but I know that it is not, of course, the case worldwide. What is the strategy and work and in the work, the right layer, which is the submucosa. Manage the complication, we will see that, and of course, try to remain calm during all the procedure. Thank you very much.
Thank you, Gabriel. It was excellent. Any question? Yes, thank you.
This is a demonstration. I just want to ask you about the learning curve. For centers that may not have as many suitable patients that need ESD techniques, what do you think would be the minimum number that the procedurist needs to undergo to be competent? And then subsequently, what will be the number for maintenance of the competency?
It's a very good question, but it's a very difficult question. European experts had a meeting several years ago, and they are not agree about the exact case. Of Wirecast. Then perhaps in my country, we are what country do you come from? Sorry.
I'm from Singapore.
Singapore. And for example, in France, we have many rectal, colon and rectal cases, and sometimes esophageal, Barrett esophagus, but not often stomach cases. I would like, because I work then in Kobe, as I told you, I would like to say that if you can, but of course many experts here can answer to begin in the stomach or the rectal cases, because we know that for the complication in the rectal cases, the lower rectal cases, even if you have a perforation, in 100% of cases, the evolution is good with medical treatment, then it's quite safe. And we know that in stomach, the wall is thicker than in esophagus or a colon lesion. Then I would recommend you to probably to do at least 20 cases on animals, but it's okay. Perhaps other experts can say more or less. And before the 20 cases on animal model, I recommend you to begin in easy location for tumor in easy location. Easy location means lower rectal lesion or stomach in the antrum. This is a
demonstration of Wirecast.
And after perhaps esophagus, because probably complications are higher for esophagus, and the consequences of the complications are probably higher, yes, for the patient.
You want to comment about this?
Yes, I'm going to represent the learning curve in my presentation. According to our data, at least 30 cases are required to master
this is a
the
demonstration
procedure.
of Wirecast.
Of course, a supervision of the expert endoscopist should be mandatory and essential.
We have time for another one? Yeah. Oh,
my name is Chris from Singapore. Thank you very much for that wonderful talk. I wanted to ask you about injection solutions and to ask whether you've used, because hyaluronic, of course, is very expensive.
This is a demonstration of Wirecast.
Have you tried Gelafusin? Or any others?
Yes, I use Gelafusin, but only in my lab. But for patients, we use a mixture of glycerol and dextrose and serum, which is very cheap, and yes, it works well. But
excuse me, the other substitution is the eye drop solution.
This is a demonstration of Wirecast.
I've tried actually methyl cellulose in the past, and but the problem is that it comes only in tiny bottles. And in small bottles. But the problem I found with methyl cellulose is it causes pain, and especially when you use it in the stomach and in the esophagus, they get pain, half an hour, 1 hour later, and you wonder, is this a perforation or is it something else? But with Gelafusin, no such issues at all, and it seems to work very well, and it really lasts a long time.
This is a demonstration of Wirecast.
Mm-hmm. Yes, I never use it in patient, but.
Gabriel, you mentioned about US, the role of US. And in your presentation, you show 80%, around 80% in sensitivity and also specificity. So it means that we have at least 20% of under or overestimation. So you think US is mandatory?
This is a demonstration of Wirecast.
ESD in all cases or only in selected cases?
Yes, I think it's only in selected cases, and in my slide it was in esophagus, but we can also say that for the rectal cases, not 100%. Then I think it's one of the tools we have to predict the depth of invasion. I remember that in Kobe, they didn't use very often US, but they used more often classifications with magnification. And as I told you, we don't use this kind of classifications in France because we are very beginner in terms of magnification characterization. And I think that probably it can help to make the decision. But finally, if you have US T1 and 0, you have to resect, and the histological result will be the gold standard, the decision, final decision, of course.
Okay, thank you very much.
Thank you
It was
very much.
excellent.
Thank you.
Thank you. Excuse me. Next speaker, I'd like to invite Professor
This
Mariko
is a
Mai
demonstration of
from Japan.
Wirecast.
She's speaking about optimal setting of electrocouters in the environment for ESG procedures.
No need of this.
So Mariko stayed with Professor Toyonaga in the Morita in Kobe for many years, and now he moved to another hospital in Osaka. He has a great experience in this procedure.
This is a demonstration of Wirecast.
Thank you, Chairman. Good morning, ladies and gentlemen. It's my great honor to have a chance of presenting optimal settings of ESD and environment for ESD procedures by courtesy of Mr. Mr. Yoshimura and Dr. Toyonaga, who are very excellent staffs in Kobe University.
This is a demonstration of Wirecast.
Incision by electric surgical unit is to produce phreatic explosion of cell membrane with vapor pressure and heating tissue rapidly over 100 degrees with continuous movement of high frequency current device tip. Coagulation by ESD is to produce drying shrinkage of tissue by vaporization of intra and extracellular solution and heating tissue gently under 100 degrees. Difference of output wave.
This is a demonstration of Wirecast.
Difference of output wave for make speed fluctuation of joule heat quantity during wear time. ESD aim to get tissue disorganization, incision or coagulation by joule heat. 300 kilohertz to 5 megahertz spectrum. Interchange electric current hardly produce electrolysis nor induced current without electric shock. Electric discharge
This is a
proportional to
demonstration of
voltage is
Wirecast.
generated and voltage rather than 200 volt. The heat it works very. Heat coagulation depth on inside section is proportional to the strength of electric discharge. Joule heat rapidly generates heat according to increase of current density. Actually, current density increases according to sharpness of the device tip with small contact area to tissue.
This
and
is a
effective
demonstration
heat
of
effect
Wirecast.
is instantaneously provided. On the contrary, current density decreases according to the dullness of tip with large contact area to tissue and effective. On the contrary, current density decreases according to the dullness of tip with large contact area to tissue, and effective heat effect is not provided instantaneously. Incision speed is a moving velocity of device and the manipulation of scope.
This is a
Incision speed
demonstration of
control
Wirecast.
closely and participate in the selected mode, output wave pattern, effect and traction, and contact area, current density. Series connection type electric circuit is compared to monopolar system. And the electric current flow in the circuit consists with device, human body, and return electrode. The current density increases extremely at the device due to small contact area, but at the return electrode,
This
which
is a
collects
demonstration
current,
of
the density
Wirecast.
decreases dramatically. This system brings instantaneously incision or coagulation at the device and safe collection of current without heat effect. In bipolar system, the device and the return electrode are integrated into the tip of the device. The electric current flows just between these two electrodes. There is no need of return electrode on human body. In monopolar system, we need to firmly attach return electrode on flat
This is
part
a
that has
demonstration of
appropriate distance
Wirecast.
from tip of device. We must be aware of direction of return electrode. Heat burn is caused by concentration of electric current. We also must be aware of turn-off of return electrode. Heat burn is caused by concentration of electric current to the other side, and a two-plane, it works automatically. A two-plane type return electrode is safe because a sensor will detect turn off of electrode. Electric conduction is
demonstration of
basically
Wirecast.
indication for the patient with pacemaker implantation. Even system is in bipolar. Reluctant to use a monopolar system, we must be careful about the selection of part and the precision of return electrode attachment, not to put hard heat between device and the return electrode. LB produced most popular automatic output control type ESU, improved Bio and after ICC.
This is
Bio
a demonstration of Wirecast.
I and Q incision, and it has newer mode of dry cut and swift coagulation. It has double maximum electric return current amount and 4 times joule heat than ICC 200. Output mode of general ESC is often output power maintaining type. Voltage is controlled by fine-tuning of output depending on setting of work and load output. There is some time lag at the output start, and output always constant and maintained. While
This
newly
is a
invented
demonstration
ICC
of
and Bio have
Wirecast.
automatic output control type, voltage control type, or electric control type. There is no time lag at output start, which with a power peak system and required output supply is opportunistic. The electric resistance of tissue changes according to electricity. Output power is maintained regardless of change of resistance, therefore quality in season and coagulation cannot be constantly maintained. Coagulation depth
This
is notably
a demonstration
influenced by
of
the
Wirecast.
decrease of voltage associated with the environmental change of electric conduction. Excessively increased output make unexpected sharp electric discharge, which raises the frequency of perforation. In the automatic output control type, automatically regulate output supply, especially at the incision start, which require output. The output power was reinforced by power peak system and prevents time lag. Required power is opportunistically supplied with
This
installed
is a
output.
demonstration
This
of
maintains
Wirecast.
quality of incision and dissection. Voltage control reliably maintains selected voltage and the effect regardless of output power. In brief, constantly maintained. In brief, constantly maintained voltage keeps the coagulation depth at the incision edge, as well as enables the best cutting quality at the incision. This voltage control produces appropriate coagulation depth in different situations by supply of enough
This is a
required
demonstration
power.
of
That is,
Wirecast.
voltage control enables excellent reproducibility of coagulation depth in every situation, incision, dissection, and hemostasis. For the selection of the output of ESE or LB, we must consider the difference between the devices. Furthermore, we must understand the different output wave or modes. Duty cycle is a period when output wave actually appears within the modulated ratio. When consecutive non-modulate outcut is defined as 100%,
This is a
intermittent
demonstration
wave
of
forced
Wirecast.
coagulation is modulated to 20%, and dry cut is modulated to 30%. The difference of duty cycle in the different effects of incision coagulation. Dry cut incision with more excellent hemostatic property than outcut was enabled by power peak system, which brings sharp startup of output. Dry cut dissection has more effective than swift coagulation, although from a voltage lower than the latter. And installed output power
This
only
is a
shows
demonstration of Wirecast.
In actual output, the work amount is always ordered for the maintenance of selected voltage by effect. Therefore, we often recognize output shortage in applying electric current. Power peak system is a system and a function. It works only in the initial incision require output, which is more powerful than setting. The incision start is one of such situations. The momentary release electric conduction produces a shrinkage of tissue and gap.
This is
The
a
resistance
demonstration
tissue
of
rapidly
Wirecast.
rises, and the electric discharge, sparkle, and arc become instantly possible. The incision of Bio power peak system produces the maximum power under the load limitation cancellation within 300 watt And however, the power peak system does not work in coagulation. Therefore, time lag between the start of electric conduction and gap in coagulation is larger than that in incision. In order to make up for this time lag, output power setting is important for
demonstration of Wirecast.
or voltage control mode. The rapid step technique exactly adjusts a single current duration by appropriately short period. Then it controls incision speed and prevents excessive dehydration and carbonization. During incision, long single current duration access incision speed and cause bleeding and also causes carbonization. In the case the knife is congested, in order to prevent this situation, current duration should be appropriately limited. When we use high cut of end cut by rapid step technique, incision speed is maintained with prevention of excessive dehydration. If you step longer, the continued output eventually enables the sufficient coagulation and the selected effect. The same output wave can produce different electric conduction results by proper application of duration period.
This is a demonstration of Wirecast.
Post-coagulation mode of bio enables voltage arrangement according to output power below 60 watt by selection of appropriate voltage from 4 phases of effect. This control particularly enhances the reproducibility of coagulation depth and also avoids the risk of unexpected sharp electric discharge. Over output power 60 watt, selected voltage from effect makes complete voltage control operation, and this control prevents fluctuation of voltage caused by change of electric conducting environment. In swift coagulation of bio, voltage control reliably maintains coagulation depth by the selected voltage and the effect regardless output power. ICC end cut has 800 millisecond output wave consisted of high cut, 50 milliseconds incision, and 750 milliseconds of coagulation.
This is a demonstration of
Wirecast. By 4-level effects and regulated by output power. Power peak system for incision start for output power setting. Bio has fixed voltage at each mode. End cut I has 500 voltage. End cut Q has 500 voltage to 700 voltages in gradual manner. It needs no regulation by output power, and arc regulation works depending on peak voltage.
This is a demonstration of Wirecast.
High frequency snare. Inversion bio found for too high voltage of 700 voltage sharply rise up. If snaring is too tight, first spark causes an instant dissection and bleeding. The voltage of after version 172, the gradient increase of voltage from 500 to 700 regulates snare incision speed and coagulation. This without assisting system similar to power peak system,
this
it cannot
is a demonstration of Wirecast.
Electric arc control, which require high electric current under low voltage. So in the cut IQ instantaneously change electric discharge to arc discharge by quick high voltage and maximum electric conduction. This is the impulse properties. At the start of arc of discharge, the voltage is maintained to maximum, and the discharge is also maintained under proper electric current. End cut IQ has utilized
Wirecast.
Consisted of hemostasis, cut duration, cut interval, and hemostasis is regulated by 4-level cut effect, incision period by 4 level, and interval by 10 level. In end cut I effect, hemostasis is regulated by 4-level effect, and the coagulation intensity in between each duration was selected by effect. In end cut I, coagulation is off at effect 1, and coagulation on at effect 2
This is a demonstration of Wirecast.
Coagulation density increases from effect 2 to effect 4 by increasing frequency wave pattern, even though the voltage is only below 180. In end cut Q effect, voltage of effect 2 is only 100 80 voltage without electric discharge, and that effect 3 to 4 is 500 voltage with electric discharge. Effect 4 has higher frequency of wave. When effect level increase, coagulation
This is a
density also
demonstration
increase.
of Wirecast.
In NR-cut IQ cut duration, the output period with high cut incision was selected by four-level cut duration. When incision period get longer, incision speed become more fast, and cutting duration level get higher, incision period get longer. In the cut IQ, there are 10 level cut interval, and incision and coagulation is alternatively produced by cycle settled by cut
This
interval.
is a demonstration of
In cut
Wirecast.
IQ, incision cycle interval level increases, and the coagulation period also increases with incision interval. In cut IQ, the wave pattern with highest incision performance is the effect 1, cut duration 4, and cut interval 1. That with the highest coagulation performance is effect 4, cut duration 1, cut interval 10. Marking by APC is easily even in the direct direction of the tangent.
This is a demonstration
but it has
of
risk
Wirecast.
Of gas in mucosa layer when APC work very close to mucosa. Soft coagulation can produce shallow and distinct round concentric marking. Precut is for IT knife into muscle layer of mucosa. The acceleration of incisions spread directly cause bleeding, and end cut is appropriate for its excellent regulation of incision speed. Mucosal incision should be done at the same incision speed in every direction. Regardless of devices, end cut is suitable output.
This is a
The
demonstration
submucosal
of
dissection is most
Wirecast.
important for ESD procedure. We must adjust output with consideration of electric discharge, lunge, and incision speed to prevent perforation and bleeding. Soft coagulation with hemostatic forceps is used for major bleeding. Forced coagulation and soft coagulation with device are used for precoagulation of small vessels and minor bleeding. Here are our basic output settings of each procedure. This is for gastric
This
ESD
is a
using flash
demonstration
BT
of
2.5
Wirecast.
mm and radial jaw hold. And this is setting for the esophageal ESD using flash BT 1.5 mm and coagulation. Compare that to that of gastric ESD, effect is higher, but cut duration and interval is lower in mucosal incision. Effect is lower in submucosal dissection and hemostasis. This is setting for colorectal ESD using flash knife BT 2.0 mm and coagulation. Compared to that of gastric
This
ESD,
is a
effect is
demonstration
same,
of
but cut
Wirecast.
duration and interval are lower in mucosal incision. Effect is lower in submucosal dissection and hemostasis. This is also setting for the gastric ESD using IT knife 2 and radial jaw hold. Compared to that gastric ESD using flash knife BT, effect and cut interval are higher, but cut duration is lower in mucosal incision. Effect is higher in submucosal dissection and hemostasis. And for conclusion is for the safe and successful
This
ESD,
is a demonstration
just
of
and enough
Wirecast.
appropriate incision or dissection are required, with suitable section of output mode and the duty cycle, as well as proper setting of voltage and output power. Thank you for your attention.
Thank you. Some any question of the audience?
This
Okay,
is a
go ahead.
demonstration of Wirecast.
Dr. Mai. I'm Dr. Lam from Taipei City Hospital. I have several questions about the electrode. The first question is, in what kind of condition when our setting between the curtain and the core will be hard to be a different? Because, for example, when I use a needle knife or a heart
This
biopsy
is a
to
demonstration
do
of Wirecast.
Coagulation, a needle knife coagulation and a heart biopsy coagulation, the contact between the contact surface between the tissue and the knife if the contact surface area is very small, or the contact surface areas are larger, my setting is coagulation. In
This
contact
is a
surface area very
demonstration
small,
of Wirecast.
and the contact surface areas are larger. Would it the effect will be any different? And if I use a needle knife to do a coagulation, will it act like a cutting?
Basically, and when we generally use an fraction FBT, this is a short needle knife, and when the concentration is very high at the tip of the
This
tip
is a
of the
demonstration
knife.
of
So,
Wirecast.
coagulation mode is sometimes be used with careful. So when we use coagulation and some needle knife and something, and we down regulate the if BIOS the level of an effect get lower and cut interval to be short, and cut interval longer and cut duration is short. And when you use some another coagulosper or something, that is
This is a demonstration of
used
Wirecast.
For coagulation, for soft coagulation or something, for hemostasis.
I have to, if my question is, in what kind of condition, the effect between coagulation and cutting will be very close?
Yes.
Because sometimes we use
This is a demonstration of Wirecast.
forceps to do hemostasis.
Yes. If
I use a needle knife to do coagulation hemostasis, or I use half-bias forceps to the coagulation, if there's any difference. Would a needle knife do coagulation?
Yes, for the needle knife coagulation.
Act like a cutting, or
yes.
My
if
question
we
that
use
is,
coagulation with knife
This
itself,
is a demonstration of
use
Wirecast.
some kind voltage is getting not too high because it makes a spark or something. And if you use another purposes of coagulation by need knife itself, and for dissection and or coagulation, we get voltage is lower, and for the incision of some fibrotic tissue with something, and we get the effect is higher.
This is a demonstration of
That is the
Wirecast.
difference over the use of an incision dissection. If we must dissect some fibrotic tissue very quickly, we use an incision mode, and if there is no need to so much hard procedure with fibrosis, we get change the mode from incision to coagulation, cutting mode. But even and cut eye has itself
This
some
is a demonstration of
coagulation.
Wirecast.
So so difference is which result should be is to be required, cutting or coagulation in a situation difference and fibrotic tissue or not fibrotic tissue, something like that.
I have some comment. How to choose the coagulation mode is sometimes depends on the doctors.
This is a
Some doctors
demonstration of
prefer,
Wirecast.
you both prefer the forced coagulation, or during my lecture I will explain about that, and pre-coagulation with the needle knife, with the the former soft coagulation mode, but right now forced coagulation effect 110 watts, right?
Yes.
And the other doctor used the knife itself with the spray coagulation, right? Just most important thing is how to use,
This is a
how to set
demonstration
the
of
power,
Wirecast.
right? The needle knife need just not enough power, right? Because a lot of high energy going to the tip of knife and can penetrate it to the directly muscle.
Yes. So it depends on the difference of knives. then contact is wide or short, and if the contact area is wide, and some more higher power spray coagulation or something is required. But then knife tip is very short and the concentration is very close. So we use another more delicate coagulation mode, such as the forced coagulation, something. My professor, Dr. Torinaga, was always basically using forced coagulation because he get very small and tiny steps than an IT knife user.
Okay. One more question. Last question, please.
I'm sorry, I have an excessive truth.
This is a demonstration of Wirecast.
I'm sorry, I have another two questions. I think it's the same question. In the previous slides, I see the picture showed if we use a bipolar, a unipolar mode electric current setting, the electric pad, for example, we do the ESD at the stomach.
This
The
is a
electric pad
demonstration
we
of Wirecast.
put over the stomach. If there's any difference, the electric pad we put over the stomach or we put over the leg, if there is any difference.
We usually, I'm sorry, put electrode and very close to the target. So if you want to do some upper GI procedure, the electrode, if monopolar, is set around the backside because here it's very flat
This is a
and very
demonstration
close
of
to
Wirecast.
target and easy and correcting the return electrode. But you know, corrector and ESD or something, and we put an electrode around here because an electric current is instantly and smoothly get back to the electrode.
Thank you.
The next, again, Dr. Mariko. She's talking about
This
the
is a demonstration of
accessories,
Wirecast.
knives, features, and benefits.
And next,
Yes.
Sorry.
Again.
Next topic are endoscopic accessory knives and feature and benefits. Transition devices are shown in this schema. There are many devices developed from these conventional left side conventional devices, needle knife and a snare, papillotome, or hemostatic forceps. And a needle knife has advantage, and that is original when that is sharpened and
This is a demonstration of Wirecast.
especially at a region with severe fibrosis. On the contrary, discharge that has a risk of perforation and there is a rough manipulation. Hook knife has advantage that is sharp and useful in all situations, especially the muscle layer region to face vertically to the devices with picking up and tissue into front. Actually, hook part holds the inside mucosa when muscle layer face to vertically to device. And this technique is so-called
demonstration of Wirecast.
Its arm part holds the inside, forward and inside the mucosa with when muscle layer faces horizontally to device. Hook part turn to lumen, this is arm cut. And disadvantage of hook knife is that short pitch of each incision and section and delicate hand rotation by assistant is required for alignment of hook part. IT knife has an insulated tip and it enables large and speedy
demonstration
procedure.
of Wirecast.
However, a vertically standing IT knife is dull because it makes the mucosa kinked. And the mucosa should be pushed down, then the horizontally pulled into the front. And IT knife too has sharp with 3 short blades overcome on the backside of the insulated tip. IT knife disadvantage and it enables sharp dissection without pushing the mucosa down. But IT knife too is still has a disadvantage.
This is a demonstration
some
of
not
Wirecast.
high, but some risk of perforation when knife is deeply laid down. IT knife nano was developed after IT knife 2, and small tip of IT knife. Small tip IT knife nano can more easily get into narrow submucosa than IT knife 2. Nevertheless, a vertically standing knife, IT nano is still dull compared to the non-insulated knives. The flash knife is short needle knife with a thick needle
This
and
is a demonstration of
rings,
Wirecast.
and the water jet emitted from the tip of this and enable ravage of the operating fields, as well as submucosal local injection without replacement of knife. The flash knife BT is equipped with a bowl-shaped and enlarged tip in diameter, extendable to 3 lengths, which has improved and hemostatic capability and facilitating the scooping up of tissue. However, disadvantage of still some risk of perforation.
This is a demonstration of Wirecast.
Even duller than a needle knife. This is a shame usefulness of flash knife. The diameter of the flash knife is larger than that of the conventional needle knife. Its tip is dull with allowing electric current density, and therefore less likely to cause bleeding and more efficient in stopping oozing of blood compared to a standard sharp fine needle knife. Stop.
This is a demonstration of
Using the tip of the
Wirecast.
sheath as a guard, the knife is easily and safely handled to incise and dissect tissue with a slight tension and effect under direct observation. This is a schema of scooping up the tissue by the flash knife BT. It facilitated the scooping up of the inside and dissect tissue and potentially improving its operability. This is a video that improved the hemostatic capability of flash knife BT with the spark
This is a demonstration of Wirecast.
eliminating radius from the ball-shaped tip. The current density in the flash knife BT is decreased by enlarging the tip, and the hemostatic capability was improved with a spark emerging radially from the ball-shaped tip. And the water jet is not disturbed by ball-shaped tip. It facilitated the scooping up of the insides and the dissected
This is a
tissue,
demonstration
potentially
of
improving its
Wirecast.
operability. In such an horizontal dissection with an kinked and mucosa, it can smoothly follow just over the mucosal layer, and some bleeding happens, and knife itself can coagulate, and with soft coagulation, these small vessels. The application of flash knife and BT is shown in this table. As for
This
flash
is a
knife,
demonstration of
2.5
Wirecast.
millimeter and 1.5 millimeter are useful. For esophagus, shorter 2 millimeter and 1 millimeter are used. For colorectal, short 1.5 and 1 millimeter are safe. And for flash knife BT, I have shown in the last picture and the video, each length is used for incision and dissection safely. And flash knife BT was further improved to flash BT knife BT2, BT1,
This
BTS,
is a demonstration of
which has
Wirecast.
smaller knife diameter, and it improved the section amount due to the smaller knife diameter. Shape of this prevents brining of core needle. Thinner and ductular sheath achieves more flexible maneuvering performance. Additionally, small knife diameter enables more flexible maneuvering performance like this. Flex knife was the second non-insulated knife after needle knife, but it was
This
now
is a
developed
demonstration
to
of
a drum knife.
Wirecast.
Dwarf knife has improved incision and dissection ability compared to conventional flex knife, and its soft sheath is easy to bend and bring smooth followingness. But force is hardly transmitted when the region is located in too far distance. The B knife has a principle of bipolar electrode. And the current flows from tip to root of knife, and the bipolar electrode has little damage
This
into
is
deep
a demonstration
tissue, and
of
it is
Wirecast.
comparatively safe for patient with heart, pacemaker, or something. But small electric current causes low incision and hemostatic ability. And recently, several knife has developed to carry water jet emitting function following after development of flash knife. It's very useful. And mucosectomy has blade on lateral side of insulated cyst, and the insulated cyst around the blade protects the muscle layer, and it has low risk of perforation when blade is parallel to muscle layer. But blade of knife should be rotated to keep parallel to muscle layer, and it has limited use mainly for dissection. Crotch cutter has an serrated jaw which provides accurate targeting and grasping the outer side of the forceps in insulated so that electrosurgical current energy is concentrated in the blade, which prevents burning of the surrounding tissue. That enables easy grasping and coagulating
This is a demonstration of Wirecast.
inciting their targeted tissue, but not useful in all situations, especially for the region with severe fibrosis and narrow submucosal layer, I wonder. And these are the summary of characteristics each devices. And a needle knife and a hook knife are still helpful to cope with severe fibrosis. And the IT knife and IT knife 2 are useful for coagulation. IT nano has improved in coping with fibrosis than IT 1 and IT 2. And dual knife and flash knife are useful in all situations. It's make a marking by itself. The flash knife has an invented water supply function, and flash BT has improved its coagulation function, and further improvement, flash knife BTS enable better water supply. The mucosectomy has a good coagulation, and B knife is on first bipolar devices, and crotch cut has good coagulation with insulate outer frame and make a procedure very simple.
This is a demonstration of Wirecast.
Another important is for ESD is scopes or some environment. Estimation of the angulation scope is extremely important for ESD. And the error should be done within 10% of catalog. Right side is not useful for the ESD. Overtube also necessary for upper GI ESD, and fingertip of glove put on over a tube to prevent an air coming out is useful to prevent air leakage. The lubricant on scope helps smooth passage of scope through the tube. As for the accessories, the backside of foot pedal rubber sheet is helpful to put the slip resistance. And bottom hanger of instrument is better to cover with some absorbent gauze or something. Next is an attachment, and the visual field is nicely kept with clean, with transparent attachment.
As for
attachment and with insulated devices, 2 or 3 millimeters short lengths are useful, and with not insulated devices, 4 or 5 millimeter long lengths are safe. And taperless diffuse by Fujifilm is helpful for fibrotic submucosal layer. Slit and food and from top cooperation is useful because slit and groove discharge fluid in food and bring clear visual field. And this is schema of approach to fibrous submucosal layer with ST food. ST food enable a good visualization in the approach to fibrous submucosal layer. As for the slit and food attachment, slit and groove discharge fluid in this manner from food and bring clear visual field with capillary phenomenon and pressure. Additional local injection of viscous sodium hyaluronate by flash knife with inserted syringe is smooth and time-saving. Flash knife with super high flow local injection needle without bleeding. This is some video with additional local injection muco-up by flash knife. It can lift up the submucosal layer very nicely, and it lasts long. And this is a summary in accordance with widespread of ESD barriers, and knives and accessories have been developed. And it is important to understand the advantage and disadvantage of each knife, then use it properly, as well as to utilize the accessories for improvement of efficiency and safety of procedure. Thank you for your attention again.
Thank you very much. Any question? I have one that is very basic.
This is a demonstration of Wirecast.
When we start with the procedure with ESD, what between these accessories, what do you think are mandatory? We should have.
Mandatory is a transparent cap, and if the possible and water injecting and scope or water injection device, that is very useful.
Okay. And between
this is a demonstration of
cutting
Wirecast.
accessories, well, what do you use in your routine? Everything, or you have a selection? You prefer? You have a preference between?
It depends on the location and the organ. For an esophageal colorectal ESD with a very thin submucosal layer and muscle layer, we basically use a flash knife because I'm working after Toyonaga sensei. But in some cases, in very fibrotic
this is
region,
a demonstration
we
of Wirecast.
First, some another knife and a flash knife or something, but we use a needle knife still or a hook knife to conquer some fibrosis. Then, and if the lesion, especially in stomach, it is a very thick submucosal layer and a thick muscle layer, the IT knife is very useful to shortcut the dissection.
This is a demonstration
Thank
of
you very
Wirecast.
much for this very excellent presentation. In my experience, for the beginner, I use also the flush knife because of my mentor, as I told you, is Professor Toyonaga. But I think first that knife with injection is very useful, and some studies show that the duration of the procedure, perhaps it's shorter. We can discuss about these publications. And for beginners, when sometimes the case is difficult,
is a demonstration
and
of Wirecast.
you can use this grasping like clutch cutter, but there is another Sumuse, I don't. There is other tools like that, knife, grasping knife, because it's quite safer. And even if there is fibrosis, you can grasp the fiber and gently make the section. And I think, in my experience, it's like a step you can success, and after you can use the flush knife again. Of course, we prefer to use only one knife. But for beginners, it could be, I think, safer and helpful to use this clutch cutter, in my experience.
So
I don't know.
Selecting devices depends on the learning curve and the situation.
Exactly.
All circumstances should be considered.
Exactly.
Okay, thank you very much again, and we go to the next
is a demonstration of Wirecast.
Speaker is Professor Ryu, and he will talk about management of complication during the ESD procedure.
This is a demonstration of Wirecast.
Good morning, ladies and gentlemen. I really appreciate Professor Michel Delbo and ICAD Taiwan Organizing Committee for giving me this opportunity to contribute my small effort to this fantastic workshop. Last year, we missed this workshop, and I was so sorry.
This is
Today,
a
I'd like
demonstration
to
of
talk about
Wirecast.
management of complication of ESD procedure. After finishing my presentation, please don't misunderstand me as a complication doctor. This is my 15 years experiences. almost all mistakes were made by the beginning period. It would be good lesson for all of yours, I hope.
This is a demonstration
last summer
of
we have
Wirecast.
the Summer Olympic Game Rio de Janeiro. I'm sorry. She's the first lady champion of private golf. All Asian gold medal, silver medal, and bronze medal. And next Winter Olympic Game was held in Pyeongchang, Korea, in 2018.
This is a demonstration
if possible,
of Wirecast.
Join this Winter Olympic Game and enjoy this this Olympic. Okay, the complication during or after each kinds of procedures would be inevitable. The rate of complication this is our data. The breathing rate is 13%. The perforation is 2.25%, and delayed breathing is less than 0.5%. Perforation, the incidence of a perforation. I'm sorry. Incidence of a perforation is, let's focus on the gastric ESD because I recommend the gastric ESD first.
This
and
is a demonstration
next is
of
colonic
Wirecast.
ESD, and esophageal ESD is the final one. And for the beginner, I'd like to explain focus on the gastric ESD first. The incidence of a perforation gastric ESD is 1% to 5%. Mainly the perforation occurrence of perforation during some mucosal dissection is more than
This is a
pre-cut.
demonstration of Wirecast.
Delayed perforation occurred after the completion of gastric ESD. The rate of delayed perforation in one study is 0.5%. Gastric perforation have been analyzed according to lesion location, size, and also finding. It is interesting. The upper 1/3 and middle 1/3 of the gastric stomach, the perforation rate is higher than lower 1/3. Probably the gastric wall in former 2 location is thinner than the lower third, and the other reason is this lesion need the retroflexion position of endoscope, and sometimes can make a lot of more damage like that. And the larger size of lesion and with ulcers increase the rate of perforation. Breathing divided 2 types: the immediate intraoperative breathing and delayed breathing. And immediate breathing is previously studied as defined as the diminution of 2.2 gram per deciliter in hemoglobin, comparing pre-procedure and next day level. Some study revealed the 7% immediate breathing.
This is a demonstration of Wirecast.
12%. And important thing is rate of significant immediate breathing in the upper and middle third of the stomach is higher than lower third, because the large diameter of some mucosal vessels in upper and middle 1/3. The degree divided like this. Delayed breathing rate is 0 to 15%. The wide variation of delayed breathing
is a demonstration of Wirecast.
Differences in the definition. Like this, the definition of delayed breathing vary from a clinical symptom of bleeding, such as hematemesis and melena, to bleeding required blood transfusion or bleeding necessitating the endoscopic treatment. Delayed breathing usually occurred within 24 hours. Related to the
This is a
lesion
demonstration
location,
of
size,
Wirecast.
patient age, procedural time. Ironically, the more frequently after ESD in the lower and middle third of stomach is higher than upper third. The reason is uncertain. How to manage complication? The possible mechanism of perforation or others, unanticipated injury
This is a demonstration of Wirecast.
Caused by insufficient submucosal injection or miscalculation as to the gastric wall curve. Dr. Mani already introduced a lot of knives, how to use it, and I skipped. Usually the IT is the like sword, the lateral cutting, and the hook knife is the pullback technique, but the other needle knife is
This
almost
is a demonstration of Wirecast.
You should understand the basic principle how to use it, like this. And to avoid perforation, need adequate space in submucosal layer, and a sufficient amount of submucosal injection solution is necessary. She already introduced a lot of injection material. Hyaluronic acid is best, but relatively so expensive. And I used injection solution with the 0.5 cc of 0.8% of indocarmine for 100 cc of saline and epinephrine solution. This solution can make
This is a demonstration of Wirecast.
Recognizing the gastric wall curve by distinguishing the white muscle propria from blue submucosal layer. And Dr. Mani already told the transparent attachment is helpful. But after you will advance your skill, we skip the blue color to differentiate the visible vessel.
This is a demonstration of Wirecast.
In past, gastric perforation during all kinds of endoscopic resection lead emergency surgery, right? But endoscopic clip was spreaded for the hemostatic purpose, and closure of perforation using the such clip after the snare excision of gastric radiomyoma was first reported by Bimolo.
This is a demonstration of Wirecast.
After that, there were several studies of endoscopic closure with endoscopic clips for endoscopic resection related perforation, and in this study, the success rate is 98.3%. This is very good result. The three kinds of method of I'm gonna divide the three kinds of
This is a demonstration of
closure
Wirecast.
technique were divided, and single closure method with the clip. The second technique is Omental patch method, and the third one is the clip and envelope. You should understand the omentum of a stomach like this, and this is the gastric wall, the greater omentum like this, the lesser omentum here. You can see where the lot of
demonstration
omentum
of Wirecast.
is, right? The anterior wall or posterior wall is relatively free spaces, but the lesser curvature or greater the curvature area has a rich omental structures. If you make the perforation, please use omental technique together. Right? But this is the the perforation case during pre-cut like this. This is anterior lesion. Oh,
This is a
you can see
demonstration of
the other bowel
Wirecast.
movement, right? During the pre-cut, sometimes very horrible to clipping or another additional resection. Please calm down and try to check where the perforation area and take up the closer with the clip like that, and then additional injection and additional submucosal dissection like that, and
This is a demonstration of
the other
Wirecast.
another remaining perforated area like that, and clip closer again like that. Yeah, clip and clip. Almost done. This page, and after that I resected everything, and this patient, I'm following up 10 years of this patient. It was okay. And the other thing is,
This is a
as you can see,
demonstration
the
of
great
Wirecast.
perforated hole like this after resection of submucosal tumor arising from proper muscle. This is endorup and clip technique. I catch up the gastric mucosa and endorup, one side of endorup with clip, and the other side catch up and pull back endorup. As you can see, the perforated area decreased, and
This
the
is a
other endorup
demonstration of
applied
Wirecast.
like this, and big perforated hole get smaller and smaller, and then try to do clip again like this, clip and clip, I'm sorry, like this. This patient didn't have any surgery, additional surgery, and the mass
This is a
was
demonstration
measured
of
by 5
Wirecast.
centimeter, like this. The final pathology was leiomyoma. The other case, lesion located in low body of greater curvature of low body. Oh, perforation. At that time, I tried to do Irby Bio ICC 300 cc first time, and yeah, that's relatively 300 cc is more
This is a
powerful than 200
demonstration of
series.
Wirecast.
And I tried to do clip like this, and then additional injection and cut the lesion more like this. After that night, patient suffered from severe abdominal discomfort and fever.
This is a
And
demonstration
the
of
next morning,
Wirecast.
I tried to do follow-up study. As you can see, transgastric view, pancreas is, you can see the transgastric hole, through the transgastric hole, right? And I sent the patient to the operating room. And this is only one patient whom I sent surgery after the perforation. 11 years ago. Okay. The other important thing is the peritoneal tap.
This is a demonstration of
Patient with
Wirecast.
the large perforation can experience a large amount of air entering the abdominal cavity. This finding can lead to abdominal compartment syndrome. To prevent this severe abdominal compartment syndrome, we should check patient abdomen with any palpation and ask so many questions to the patient about discomfort.
This is a demonstration of Wirecast.
Severe abdominal fullness noted, don't hesitate to do the peritoneal tap. Nowadays, the CO2 insufflation is more useful and popular, like this. Okay. After that, after perforation, lot of free air in the patient peritoneal cavity like this, and then I check the patient, ask so many questions. I decided to do the
This is a
peritoneal
demonstration
tab
of
like this. With the
Wirecast.
angio needle, I inject to the patient peritoneal cavity with angio needle, and then pull back the air. Then the IV line is connected to the angio needle, and the water bottle, the air. As you can see,
This
the
is a
water, the
demonstration
air
of
is going out,
Wirecast.
right? After that, free air went down, right? And hemostasis for immediate breathing is also important. Usually, electrocautery is used for hemostasis of immediate breathing. Endoscopic clip interfere the subsequent resection procedure. The minor oozing can be controlled by
This is a demonstration
nitric
of Wirecast.
or sometimes we found a visible huge vessel. We should precoagulation with the cutting knife or the hemostatic forceps applied, and the electrocautery using the hemostatic forceps is suitable for the arterial breathing also. And the other important thing is the identification
This
of
is a
exact
demonstration
breathing
of
point.
Wirecast.
Using the water flushing is essential. Like this. During pre-cut, breathing happened. With IT knife, relatively the contact surface of IT knife is larger than other needle knife. Easy to control. Oozing, minor oozing, like this. I prefer the spray coagulation, like that. Okay, stop the breathing.
This is a
As you can see,
demonstration of
the
Wirecast.
huge perforating vessel from the proper muscle area like this. You should cut the surrounded area and isolate the vessel, and catch up little bit the vessel, and slowly the burn out. Right now I used the first coagulation effect 110 watts is better than soft coagulation mode. This is also same. This vessel is surrounded by the submucosa with the lot of amount of the fat contents like this. Please be careful the fat. Isolate the vessel with the hook knife like this. After that, catch up vessel a little bit and spray coagulation like this. The other thing is I already coagulated with knife and cutting again.
This is a demonstration of Wirecast.
Let's go fast. After that, okay. Breathing again. Then it seems to be pumping. I changed my mind and I used the hemostatic forceps is suitable for this case like this. Delay breathing is a little bit different. The different modality apply according to the period. Early days.
This is a demonstration of
artificial
Wirecast.
ulcer is relatively soft, and clip or electrocautery using hemostatic forceps is suitable. The later day of delay breathing is relatively artificial ulcer is hard, and the injection method is preferable. And the other important thing is the second look endoscopy is essential or not, but the study is ongoing
This is
right
a
now.
demonstration
But
of Wirecast.
cost effective in Korea, the cost of endoscopic procedure is so cheap, and we prefer second look endoscopy. And the other important thing is after ESD, you can see the lot of visible vessel. I recommend you the prophylactic coagulation with hemostatic forceps. This is my delayed breathing case.
This is a
After finishing
demonstration
my
of Wirecast.
ESD, at the night, patient had a severe hematemesis. I did the EGD like this. As you can see, the prepyloric area has a lot of blood clot. I took off blood clot with the snare. After that, I couldn't see the bleeding focus. 1 hour trial, I found bleeding focus here, and clip again, clean up.
This is a
This patient
demonstration
doesn't
of
need any surgery.
Wirecast.
Exceed suppression drug is helpful or not? But some study is helpful, some study not helpful. But you know, maybe all attendants understand this Chinese character, right? If we know ourselves and enemy, we can win the 100%. Thank you for your cooperation. Attention.
This is a demonstration of Wirecast.
About the audience, yes, go ahead, please.
Thanks for your excellent speech. I'm Dr. Zhou in Taiwan, and I have a basic question. When you decide to perform a needle puncture for the pneumoperitoneum, how do you decide the puncture site? It's different, yeah, location. Is there any different?
I put the patient in the supine position, and after that, I take the percussion like this, and after that, the highest point, maybe all the in the middle of umbilicus to epigastric area is best, and then puncture it. Okay?
Thank you.
This is a demonstration of Wirecast.
Congratulations on the excellent talk. Just comment about the second look endoscopy after gastric ESD. We conducted a randomized control trial to investigate the clinical impact of second look endoscopy. As a result, there was no clinical impact of the second look endoscopy. We compared the data of the delayed breathing rate with second look group without second look endoscopy.
This is a demonstration of Wirecast.
Endoscopy is not essential for the patient, right?
Yes, so the more we stop.
In my opinion, Japanese doctors' skill is best in the world, right?
Yes.
This is very big difference between the Eastern and Western, I think.
Yes.
Yeah. And it's up to each country's situation, right? And
exactly.
we should consider everything, the doctor's skill and each country's situation, right there. When I submitted my article
This is
to
a demonstration
the
of
GI
Wirecast.
endoscopy, first question was the second look EGD.
Yes.
In America, it is impossible for all patients to have a second look EGD.
Yes.
Right. It's up to each country's situation. I don't know the European, but right.
Okay.
Yes, you're totally right, because in our country, for the second look, we will need general anesthesia for the patient. In Europe, they want to be sedated, maximum sedation.
This is
but
a
in your study,
demonstration
which is
of
very
Wirecast.
interesting, there is a benefit for the patients with anticoagulation or antiplatelet?
Yes, so our studies, patient with antithrombotic drug is excluded. So as for the general population, we don't have to do the second look endoscopy. As for the high-risk patient, it is still controversial.
High-risk patient should be careful. Tomorrow, if possible, I want to show the very dangerous
This
cases
is a demonstration of Wirecast.
Okay.
And I have another question about the solution that you inject. I saw in your slide you use always epinephrine, right?
Yeah. Saline with epinephrine, 1 to 100,000, because in Korea, sodium hyaluronic acid is illegal right now, still. Yeah.
This is a demonstration of Wirecast.
Substitution, but when I use the methylcellulose, I purchased the privately methylcellulose in the U.S. because the U.S. Sell the 20 cc per one bottle. That is beneficial for me.
One question, Dr. Real. To prevent delay perforation, what do you do to prevent delay perforation? Because it's a more serious complication.
Do you mean
This is
the
a demonstration of Wirecast.
delayed perforation is serious or not? I think the percent of delayed perforation is relatively rare, but we should check the patient status after ESD. Like my patient suffered from severe abdominal pain and fever and tenderness like that, and then I found the perforation. As soon as possible, we send the patient to the surgery.
This
In
is
this
a demonstration
patient,
of
I followed
Wirecast.
this patient at the operating room. Already the patient stomach has a lot of blood in the abdominal cavity. And that's my correct decision, right? But it's up to the patient condition. Patient would be okay, we take the complete closure, it would be okay. But my patient, in my case, the patient suffered from severe symptoms after the
This
ESD
is a
procedure.
demonstration of Wirecast.
Dr. Ryu, very nice talk. Can I just ask you about use of PPI after upper GI ESD? Does anybody use infusion dose esomeprazole 8 milligrams per hour, like for upper GI bleeding? I don't believe there's any data just yet, but it would make sense since every case is probably high risk or could be high risk,
This is a
especially if you're
demonstration
talking
of
about upper body
Wirecast.
and mid-body ESD.
The breathing rate, right?
Yes.
The breathing, immediate breathing or delayed breathing rate of upper 1/3 is higher than lower third, right? Usually in our country, we do the PPI for the patient at least 2 weeks or more, right?
Okay. But what about
I don't know the
IV?
Japan.
Yes,
Please ask the Japanese
any
authority.
country, maybe
This
the
is a
first
demonstration
40
Because
of
the
Wirecast.
patient want to have any kinds of medication, but PPI is only one drug which we can give the patient, right?
Do you give? I mean, how long do you keep your patients after the upper GI ESD in hospital?
The admission day, right?
Yes, and do you give infusion?
My strategy is ESD, and next day is the follow-up.
This is a demonstration
the
of
POD
Wirecast.
Day 2 is started sips the water and liquid diet, and 3 days eat soft diet, and first day patient can come back their home. How about Japan? Almost the same, or?
Yeah, almost the same. So we set 7 days clinical pathway. Yes, but everything is covered by national health insurance. So medical cost is not so expensive in Japan. So we set 7
This
days.
is a demonstration of
I think
the
Wirecast.
Japan system.
It's up to each country's condition, but
Right,
in
right.
Korea still struggle because big hospital want the patient to be back home at least at most 2 or 3 days. In our study is 4 days, right? Some struggle, right?
So the Japan system now allows 7 days. In the past, it was three days
Yeah,
admission.
that really depends on the hospital and the organ. And as for the
This is a
esophageal ESD and
demonstration
colorectal
of
ESD,
Wirecast.
delayed bleeding rate is much less than the gastric ESD. So the patient maybe can be discharged within the 5 days.
Gabriel, what about Europe? It seems that it's
Yes,
a little bit different.
It's quite different. I think I am agree with you, but it's about 3 days. We follow the patient the day after. And sometimes it depends on the case and the comorbidities of the patient, of course. But for
This is a demonstration
without
of
comorbidities,
Wirecast.
we refeed the patient the day after with smooth liquid and smooth aliments and foods, and the 2 days after they are discharged.
So do you use infusion dose esomeprazole? Does anyone use 8 milligrams per hour?
Yes, we use, I think we don't have scientific data, evidence-based. In this,
That's
you're
right.
right.
Yeah,
That's why.
This is a
But we
demonstration
use
of
it,
Wirecast.
like we use like bleeding ulcer or
Exactly. I mean,
it's the
same for us, and I think it does
yes,
make a
but
difference. But again, there's no data, so
yes,
maybe it's a good
data.
time to do a
It
study.
could be perhaps interesting to begin a trial to have the data. But
Same is for us. Even there is no evidence to support the use of PPIs. We treat this patient as a bleeding patient for at least 24 hours.
Yeah,
At
I mean,
least,
it
at
makes
least.
sense. It definitely makes
This
sense.
is a demonstration of Wirecast.
Okay, thank you very much. And
Next speaker, Dr. Abe from Japan. He's from National Cancer Center. This hospital is the pioneer in this technique. We will speak about
This is a
learning
demonstration
of
of
ESD procedure,
Wirecast.
the Japanese experience.
Yes.
Please, Professor.
Yes. Thank you for the kind introduction. Good morning, ladies and gentlemen. It's my great pleasure and honor to be here and to talk this session. Thank you for giving me an opportunity of this lecture. My task is learning of ESD procedure, the Japanese experience. Endoscopic submucosal dissection, ESD, allows us to achieve the high umbilical resection rate
This is a
regardless of
demonstration
tumor size
of
and location,
Wirecast.
and following lower recurrence rate. And ESD also provides us to detailed and precise historical evaluation in umbilical resection specimen. However, ESD is technically much more challenging, and the complication rate is much higher than that of EMR, and ESD is also a very, very time-consuming method. So needless to say, efficient and appropriate
This is a
training system
demonstration
is
of
required to
Wirecast.
master the ESD safely. So today my talk is about how trainees learn ESD in Japan, and also what needs to be done for ESD outside. So in Japan, the ESD procedure is widely spread and accepted as a standard of care of the gastrointestinal neoplasm. So many Japanese institutions have their own training system with
This
several
is a
variations.
demonstration of Wirecast.
So I'd like to show you our training system at National Cancer Center Hospital. We usually let a young doctor firstly acquire the basic knowledge about the indication and setting, and then let them observe the assist expert procedure. And then the trainings using the ex vivo animal model, and finally ready to perform basic ESD. First step should be
This is a
pre-operative
demonstration of
endoscopic
Wirecast.
diagnosis. This is one of the examples. Before introduction of the ESD, we need to collect enough patient to do ESD. So as you can see here, preoperative diagnosis is very important. On white light endoscopy, reddish black mucosa was seen, and after spraying the indigo carmine, this region is visualized as shadow depression. And applying the NBI magnification, we can nicely see the demarcation line between inside and outside the region,
This is a
and irregular
demonstration of
microvascular
Wirecast.
and surface pattern. So early detection is very important to not only to perform ESD, but also to improve the prognosis of the patient. And also, it is very important to evaluate the lateral margin and invasion depth in detail. And also, it is also very important to be familiar with clinical indication of ESD. This is one of the examples, the criteria for curative endoscopic resection of early gastric cancer, according to the Japanese gastric cancer treatment guidelines. Blue box shows indicates absolute criteria for endoscopic resection, and yellow boxes were expanded criteria. So primary purpose of ESD is to cure the patient, not to just cut it out. It is very important thing. And also, we have a weekly preoperative conference at NCCH. We always discuss about the lateral margin of the lesion, depth, invasion depth, tumor size, and histology of biopsy, and then make a plan of the treatment plan for each patient. So it is also very essential process to avoid the useless ESD and over-surgery and keep the quality of ESD at our center. And second step is to observe and assist the expert procedure. I always ask a young resident to be next to me like this, and ask them to help my procedure as assistant, as shown in this slide. It is very essential to learn how to handle the endoscope and device, and learn the treatment process and treatment strategy, and see the management on complications such as massive bleeding and perforation. So I believe the position of the assistant is the best because they can see both the monitor and the expert hand. And actually, I was assisting my boss, Professor Saito's procedure when I was the chief resident. And the third step is the ex vivo animal training model. We established our own porcine model, and it is very nice to experience a specific scope maneuver that are not commonly performed in general and traditional endoscopy, and learn how to use ESD devices. Although using this model, the PIC models, mucosa is relatively thicker than the femur one, and we cannot experience bleeding, but